Well, there was a tendency on the physician's part to pretend that the uncertainty wasn't there, to give the patient a definitive answer, even when there was no definitive answer. And I think that's problematic. It was not helping to facilitate the diagnosis.
Hello everyone, welcome to Phi-Sci Conversations about Philosophy and Science. Joining me today is Ashley Kennedy. Ashley is an associate professor at Florida Atlantic University. She primarily works in philosophy of medicine and general philosophy of science. And in particular, her recent work has focused on philosophical problems pertaining to medical diagnosis. And she has recently, this year, published a book titled Diagnosis, a Guide for Medical Trainees. Ashley, thanks for speaking with me today.
Thanks for having me.
So, can we start by discussing what are some of the philosophical problems relevant to diagnosis?
So there are a lot of relevant problems, and I think perhaps the one that I'm most interested in and is an overarching theme of my book is the question of what counts as evidence for a diagnosis and who decides. So there is this idea, I think, that it comes from evidence-based medicine and considerations with treatment that is sort of filtered over into diagnostic practice, that somehow measuring signs in a patient, things that can be measured objectively from the outside rather than symptoms, is sort of the best way to facilitate an accurate diagnosis. But that's actually not the case. And I argue in the book that we need to be pluralist when it comes to what counts as evidence for medical diagnosis, and that we ought not to think of things like the patient exam or patient history as lesser evidence than, say, some kind of blood test or some kind of MRI measure, etc. And so the question, what counts as evidence, who decides, I think is really important in all of medicine. It's especially important in diagnostic practice, and that's because it helps to facilitate, when you get it right, when you get the evidence question right, you facilitate accurate diagnoses. And we care about that because accurate diagnoses, I think, are the first step in facilitating effective treatments.
Okay, in your book, you mentioned this statistic, which I found pretty interesting, which was that, I think I've got this right, 80% of diagnoses can be accurate based on just taking a good history of the patient. Did I get that right?
So based on the patient history alone, sometimes the patient history is called the patient interview, and so it's just talking to the patient, just words, back and forth between the clinician and the patient. 80% of the time, just based on that, one can arrive at an accurate diagnosis. And then another 10% of the time, if you add on the physical exam, so now we're at 90% of the time, you don't even need to run a test. And I think, that's a pretty shocking statistic. I like to talk about that with my med school students because they're always quite surprised as well, because there's a strong emphasis on what's considered to be, better or stronger evidence that comes from blood tests, scans, and things like that. And I just try to highlight for them, these studies that show actually talking to the patient is really the most important thing that you can do in the clinic. Yeah.
Right, okay. Well, that raises an interesting question about what to do when you can't talk to a patient. So, like, if a patient is unconscious, or if a patient has like a psychosis. Okay, but in routine cases.
Yes, absolutely true. And so or a child, and so then you would talk to a proxy. And there's a joke in medical circles, although perhaps it's not a joke, is that in that case you should call in a vet, because veterinarians are trained in diagnosing patients who don't speak. At least don't speak, human language, right? And so there are other things that you have to do when you can't take a patient history.
Yeah, that's interesting. It's an interesting joke, but I've often wondered how my vet does it when I bring my dog in. How my vet reads the signs without speaking to my dog. It's pretty impressive.
It is impressive. It's very impressive. Yeah.
One of the key questions that you've been interested in past articles that you've published, and also in your book this year, is about evidence of a different sort, namely evidence of how to evaluate the reliability of diagnostic tests. So can you say how are diagnostic tests evaluated, or how ought they be evaluated?
Right. So, first, perhaps I should say a bit about the way treatments are evaluated. And the standard now, and since the 1990s, is randomized controlled trials. So, you take a new treatment, you usually test it against an older treatment, sometimes against a placebo. Um, and for the most part, that has not been the case with evaluating diagnostic tests, although that's starting to change. I'll say more about that in a moment. For the most part, we've just, done sort of observational studies, just sort of looked at the patients. Okay, I think you should get the new test. I think you should get the old test. And there hasn't been this randomization. Um, and recently, in the medical literature at least, there's been this, a bit of an argument back and forth. Should we be doing with diagnostics what we are already doing with treatments? And it's an interesting question, but I think that randomization is actually less important when it comes to diagnostic test evaluation than when it comes to treatment evaluation. And that's simply because the randomization process is supposed to get rid of, or at least not get rid of, lessen certain things like allocation bias. And so if you imagine that there's two treatments, an old one and a new one, both the researchers and the participants in the trial are probably going to behave differently if they know who is getting the treatment and who isn't. But those reasons why people behave differently, maybe they have an expectation that the treatment is going to do something great for them, or maybe the researchers are going to be more attentive to the patients who are getting the treatment rather than placebo. Those things seem far less likely to happen in the case of diagnostics. I'm not saying that they could never happen, but it just seems that they're far less likely to happen. And so we might be better served, I think, just with looking at the things that we do know that would affect the test. Right? So I use an example of a thyroid test for TSH. This can be affected by certain medications. It can be affected by age, etc. And so if we know those things, then we should try to evenly distribute those things into the old test group and the new test group. Obviously, as with treatments, we're not always going to know what all the confounding factors are. I certainly wouldn't make that argument, but it just it doesn't seem like we really need to spend all the resources on randomized controlled trials. I think that we might be better served spending those resources elsewhere.
Right, okay. When I first read your article, the article titled Evaluating Diagnostic Tests, I was actually surprised that there was this movement to
Yeah.
use randomized trials to test diagnostic tests, in part
Yeah.
because I had in mind, why wouldn't we just evaluate diagnostic tests in the following way? We have a gold standard
Right.
for diagnosis,
Yeah.
a reference standard, to use the
Yeah.
term that you use, and then we just
Right.
deploy the new diagnostic test on some defined population, and then we just see the percentage of
Right.
times that that new test gets it right with respect to the reference standard. So what is wrong with that sort of simpler
So I
approach?
think for the most part, there's really nothing wrong with that. And I think when I wrote that article, it was still a bit of an open question in my mind. But now, several years later, I'm thinking, we really don't need RCTs. So that point perhaps didn't come across strongly in the article. And now my view, sort of looking at these things over, I guess it's been 4 years since that article, I'm thinking, yeah, we really don't. I don't think that there's really anything wrong with that, to be honest. For the reasons that I said, I mean, it seems far less likely than in the case of treatment that someone is going to behave, and differently because they're getting one test versus the other. Not impossible, but not very, very likely. Now, there are times when we don't have reference standards exactly. For example, with COVID testing, that was new, but we had the technologies that, PCR, for example, we've been using PCR for a long time. So it can be a little bit harder when there is a new disease and there's not a well-established standard, but I don't think an RCT would have helped in that instance either.
Yeah,
Right.
yeah. It's interesting to get your reflections on your view about the topic that you wrote this article about a few years ago, because I use this article, it's a nice
Yeah.
article, and I use this article in teaching students. And so I hope that my
Yeah.
students will watch this interview and they'll see your sort of matured reflections on the subject.
I actually reread the article yesterday before this interview. So it's been a while since I read it, and I I pretty much agree with everything that I said. It's just I've further developed the views in each of the cases. So,
Yeah.
um,
Yeah.
but I was sort of curious. I mean, I guess we all do that. We look at something, a few years later, and wonder, do I still think these things? The answer is yes.
Sometimes.
Yeah, I mean, in this case, right?
Yeah.
In this
Okay.
case, yes. Yeah.
Yeah. Another topic that comes up in that article and also in your recent book is the notion of diagnostic value. So you give this example of a genetic test for Huntington's disease, a scenario in which there's no available treatment, and so one might think, well, getting a diagnosis for a condition for which there's nothing useful that can be done for a person with that
Right.
condition itself might not be very valuable. So what are the relevant considerations for
Yeah.
the broader notion of diagnostic value?
Right. So I started thinking about this because I was sort of reading through some medical school textbooks in preparation for this is a class that I taught. Gosh, I don't know. Maybe back in 2013, it was going to be to second year med students. So I thought, well, what are they learning in their second year? Sort of just reading, not reading everything, but sort of just glancing through these textbooks. And one thing that continually popped up was this sort of catchphrase, and it was in all of the books that I opened. Never do a test unless it would change what you would or could do for the patient. And so I started thinking about, well, what does this mean? Would or could do? How do we parse that out, right? And I think what was meant, and these are second year medical school textbooks, so things, maybe become more complicated in later years. Um, the idea was, unless it's going to change something that you can measure in the clinic, don't run the test. And I thought, well, that seems a bit narrow. Here's a philosopher, these students and clinicians have to act in real time in real places, And so I want to, sort of be fair in my evaluation, but my first thought was, this is far too narrow. What if you couldn't do anything that would change the clinical outcome for the patient? But it just seems that, there are cases where it's going to do something for the patient. Now, what kind of something? Well, we do have studies that show that patients, for the most part, and I don't want to lump all patients together because patients are individuals, but patients, for the most part, actually do want to know about their diagnoses, even when nothing, I can say nothing loosely, nothing can be done. At least nothing can be done to change, sort of the outcome. And there's some kind of epistemic benefit there. Now, I've never, read the word epistemic in any medical school textbook, right? But that's something that philosophers think about. I think about it a lot anyway, right? And so I am not exactly sure what to call it. I called it one thing in the article and another thing in the book, but there is this sort of extra clinical value. It's one term I've used. It's not the kind of value that we can measure in terms of blood pressure or, cholesterol level or cancer is there, is not. But there's still some kind of value. And most patients actually do want that. And sometimes there's even a bit of amelioration of symptoms. I mean, this is not a cure, right? Just knowing what you have. Sometimes we even see a bit of amelioration of symptoms just when the patient finds, aha, this is what's going on, which is a pretty neat thing. I mean, it's not a cure.
Sure.
I don't think in any case. But sometimes people do feel just a little bit better.
Sure.
Because they have this epistemic benefit.
Sure. Okay. I want to ask you a slightly different question about your approach to the subject. So, in your book, you worked as a standard analytic philosopher, engaging with some of the contemporary literature in philosophy of medicine. But one of your interesting approaches was you described real cases, and I take it that some of these cases were cases in which you actually observed as a sort of shadow participant in the clinic. Can you tell us about this experience, like why you did this and what you learned from this experience?
Yeah. So all of the real cases, unless otherwise noted, were ones that I observed, and then even a few of the ones that I call fictional, I had to change a lot of details, to make sure that no one would be identified. So there's actually almost all of the cases in the book are ones that I personally observed in clinic, and I observed in several different hospitals. New York, Florida, South Carolina. why did I do that? Because look, if I want to be writing for an audience that's doing real things in real places for real people, then maybe I should spend a little bit of time at least observing, how this practice happens. And what I was doing, well, first I should say that especially when I was in New York, I spent a few weeks shadowing in the emergency department up there. I really, really had a newfound respect for physicians. That's who I was shadowing, physicians, because it is not easy to have to act um, under conditions of uncertainty. And there's always some level of uncertainty. Sometimes it's a low level, sometimes it's a high level. And yet there's a real patient there in front of you. That patient is suffering, maybe even that patient is dying, because this was the emergency department. And you have to do something, right? So I really, really had that in the back of my mind while writing this book, right? So I can't be too harsh and say, oh, you did this wrong, whatever, because I'm not the one who's actually making the decision. So the idea was I wanted to look for patterns, really. Are there any kind of identifiable patterns in the way that these clinicians are reasoning through to a diagnosis? And some of the cases I observed in other hospitals were not in the emergency setting, but I also wanted to be in the emergency setting to see, under this time crunch, is there a different sort of way that physicians reason? And look, I mean, there are people that have spent much more time in the clinic observing than I have. So I certainly wouldn't say that I'm the foremost expert on clinical reasoning. But even just these few years of observing in different hospitals really taught me, well, first of all, gave me new respect for physicians, and really just taught me a lot that yes, there are patterns, and those patterns, interestingly, are usually not taught, at least not in U.S. medical schools. Many clinicians learn to reason through to a diagnosis just by watching, physicians that are ahead of them. I think that that's actually not a good thing. I think that part of the motivation of writing this book, I think that diagnostic reasoning and diagnosis in general should be a course in medical school. And that is to improve this practice, right? So there are things that I could see patterns that were good, and then patterns that were really not good. And so I had those in mind when writing this book as well. So one thing that's not good that I saw a lot is that when there's an uncertain case, and this happens fairly often, nobody likes it. By nobody, I mean the physicians and the patient. And there tended to be this, there was a tendency on the physician's part to pretend that the uncertainty wasn't there, to give the patient a definitive answer, even when there was no definitive answer. And I think that's problematic, not just because, we want patients to be told the truth, but because it was not helping to facilitate the diagnosis. And so that's a pattern that I think was there. It was not so good, and I tried to highlight that in the book. What can we do? We can't just wave a wand and get rid of the uncertainty, but we can identify it, acknowledge that it's there, and communicate that. So.
Yeah, the role of uncertainty really comes through in your book. You do emphasize it in several chapters, and I appreciated that. So if you were to consider like one takeaway lesson for medical trainees or current doctors or patients about diagnosis, would that be on the focus of uncertainty? Would you be emphasizing humility among physicians and awareness among patients about the role of uncertainty in diagnosis?
Yes, I mean, choosing one takeaway is difficult, if I'm choosing only one. But if that was one of them, absolutely, yes. This idea of epistemic humility, and that's not a term that I coined, that's been around for some time, but it absolutely applies in this case. And that doesn't mean not acting. That doesn't mean, pretending that you don't know things when you do. But it just means, look, here's the evidence. Here is what I do know. Here's what I don't know. And I think in nearly every case, this should also be communicated to the patient. And again, it's not just because we want doctors to be nice to patients. We do want doctors to be nice to patients. That's great. But it's far more important than that. This is about accurate diagnosis, effective treatment, and so on and so forth.
Right. Well, Ashley, thank you very much for the conversation.
Thank you.